All right, gang, we'll talk about Chapter 11 today, Special Populations, and wanted to start by hitting one of the videos that you watched for this chapter. And this was specifically the one about LGBTIQ people talking about their experiences in accessing healthcare. And I thought the example of Nunzio, who is a trans man, being treated for polycystic ovary syndrome was an interesting point. So women with PCOS produce higher than normal amounts of male hormones. And so this can create an imbalance in their body to skip menstrual periods and makes it harder for them to get pregnant. It can also cause hair growth on the face and body and baldness, and it can contribute to long-term health problems like diabetes and heart disease. So Nunzio mentions his physician wanted to treat him as if he were a cisgendered woman, even though he's biologically female, but they were treating him as if he were a cisgendered woman who wanted to be able to have children, right? So one of the points here was PCOS makes it harder for women to get pregnant. So this is not a concern for Nunzio, at least according to his own explanation. So what you're hearing here, and what I think you heard throughout the video, was providers not listening. And so that's kind of this theme that I'm going to hit on a lot in this lecture on this topic. So I thought I'd talk a little bit. I'm not going to repeat most of what's said in the text. I thought I'd talk a little bit about the LGBT population, and I borrowed these next couple of slides from the link below. So LGBT, as you probably know, LGBT populations and individuals face discrimination of a variety of forms. So among LGBT people, they've faced a lot of discrimination, not only by strangers, but by people who are close to them. I have personal friends who, when they came out to family members, were rejected by their family members. They had friends reject them and cease to be friends with them. Also listed here, people with this LGBT people face heightened threat of physical assault. They are discriminated against in the workplace, and youth in particular face a variety of challenges. I mean, it's hard enough, as you all know, to go through high school, never mind having something that sets you apart from the median. Among transgender people, also a lot of physical assault, and then again, also discrimination in the workplace. So these are the things that, if you're a healthcare provider, these are the things that your LGBT patients are potentially facing. And as a health policy person, analyst, you have to bear this in mind at the population level. So in healthcare, as we heard in the video, a lot of prejudice from providers, and hopefully this is changing. I've spent some time talking with a gay physician who operates out of Exeter Hospital and Core Physicians, the associated medical group. And one of the things he's working with is to make the Exeter health system more LGBT friendly and to help providers understand the special needs that this population has. So you can see some providers, get anxious about this. They don't want to touch them. They blame them for their health status. Most of this is just ignorance and a lack of familiarity. Transgender people have an even more difficult time, sometimes being denied, even denied healthcare. So disparities in the population include, higher levels of STDs. We've talked about this before, gay men are still the highest population with the most prevalence of HIV. High levels of anxiety and depression related back to discrimination and social rejection. Suicide ideation and attempts frequent among people who don't feel supported, right? Substance use, again, related to isolation and rejection, smoking, and just generally lack of peer and family support. See a high rate of homelessness, especially among younger members of the population. So that's a bit about, this is one way to think about a special population. The book didn't talk to LGBT much, so I thought I'd use them. But, we can think about special populations in healthcare in a wide range of ways just by looking at the population and beginning to break it down into smaller groups, right? So you can look at women, children, the elderly, LGBTQ plus. So we just talked about. The book spends a fair amount of time talking about racial and ethnic groups, but you can also think about religious minorities. So how do you treat some religions have differences of opinions about how members should be treated. Income is a huge factor, and we'll talk a little more about that. Rural versus urban populations. And I've asked you to watch a video about the incarcerated population, so you'll be talking a little more about that later. Your book looks at kind of the Asian, white, and Hispanic and Black population. So I thought it'd be interesting I wanted to make a point of showing household income by race and ethnicity. And these numbers are all in 2019 numbers, so they're adjusted for inflation. And you can see, there is a significant disparity between the different groups. Your book does a nice job of breaking down the Asian population into its component parts. And if you remember, back in the first week, I asked you to watch a video where Hans Rosling showed the progression over time of income and length of life. I'm blanking on the mortality rates, and he broke China up into the folks who lived in the big urban centers had the same expected life as people in any advanced country, many of the Western countries, and then the rural population of China was closer to some of the populations of Africa. So it's important not to, or the point I'm trying to make here is it's important not to look at people as, as just member of a particular population, because there's a lot of variation within a population. But one of the points that's worth thinking about is the social determinants of health that we've talked about, such as transportation, access to nutritious food, the ability to exercise, and then especially social support, which is a major factor for LGBT health, right, is heavily influenced by household income. If you are operating at a relatively low household income, then you are going to have a harder time with many of the social determinants that are directly related to income, such as, again, transportation, quality of housing, and so forth. But, like the book did, I wanted to break down the income. And so this is from the census, and looking at, and this is 2019 as well, looking at the quintiles. So we're taking the same four groups, but we're breaking them down just in the 2019 year into the bottom fifth of the population, the second to the bottom fifth, the middle fifth, the second from the top fifth, and then the highest fifth, and then the top 5% kind of separately. So this group is a subset of the highest fifth. And again, the Asian population is the highest. But what I want to point out is there are poor Asian households, and there are very wealthy Asian households, and the same is true for each of the racial groups. And we have this all races. So this is a blend of everybody, this green line in the middle. And the other thing to keep in mind when we look at statistics like this is household, right? So this could be, when you say household, this could be a 25-year-old recent college graduate living by herself, in Boston, making, $98,000 a year because she's maybe an engineer or something like that. Or it could be, a family of four with, two people, two adults working and jointly earning $76,000 a year, right? With two children. Could be, a low number like 17,000. Could be an elderly person, maybe a widow, who is living in a house that she paid off 20 years ago and is living off her Social Security. So the income is relatively low, but then she has a significant asset, the house, that maybe is worth $300,000, right? So even though she has a low income, she has a significant asset of great value, where she doesn't have to pay rent because she lives in a house that maybe she and her spouse paid off before the spouse passed away. So it's tricky to look at household incomes without knowing all that detail. And part of the point I want to make here is when you aggregate, you lose the granularity, you lose the ability to really understand what's happening. All you're seeing are these lumpy numbers that give you some ideas. But again, there are poor whites and there are wealthy Hispanics and wealthy Black households, right? And so the many of the challenges that we're talking about when we talk about determinants of health are kind of in this side of this graphic, right? If you're living in a household, probably I mean, this is just me thinking out loud here, but if you're living in a household that is making less than $68,000 a year, especially if you're a family, say a family of four, making less than say this middle fifth, so you're on this side, you're probably going to have a hard time. You're probably going to have a hard time paying for healthcare. You're going to be challenged in a variety of different ways economically, and the economics lead to other forms of stress and strain. One of the studies that I did a while back, and I mentioned it, I think previously you watched the video I did talking about my food desert study, but I also did a $3 diet study where I worked with a colleague of mine who was a professor in the Master's in Nutrition program. And I did like I said, I did a study where I only ate on $3 a day. So I only ate food that cost $3 a day or less. And my colleague, noted, and she was primarily a clinician, and she said, I always tell my patients to, eat more fresh fruits and vegetables, but she had never really paused to think about how expensive fresh fruit and vegetables was until she saw me trying to function on a relatively low food budget. And so one of the things she realized was when she deals with, or one of the things she said coming out of the study was when she dealt with people that she knew were from a lower socioeconomic status, so a population that had lower household income, she would advise them to, if they can't afford fresh fruits and vegetables, to choose frozen, because frozen fruits and vegetables are dramatically less expensive and the nutritional value is nearly as good as fresh. So the point of looking at income is to say that income drives much of the social determinants. You can overcome the social determinants if you have enough income for most of the social determinants. So we want to be careful about generalizing around race rather than being specific around income. Now, that said, income, it has been shown, has its own unique effects. And there's this idea called the social gradient. So a gradient is like a slope, and people who are at the top of the slope are your upper class people, and people who are at the bottom of the slope of the social gradient are your lower class people. So a study was done in Britain, in London specifically, at Whitehall, and Whitehall is this big government building where the national government has most of its offices. And so they employ, so it is the British Civil Service. So these are the federal, no, they're not federal because Britain's not a federation. It's not a federal organization, but they're the national civil servants. And so they're all employed by the British national government. And so they all have, stable incomes. What was found, they did 2 large-scale studies. I think one had something like 10,000 people in it. The other had 17,000 people in it. And they looked at people all across the income distribution within the British civil service. So you had kind of your entry-level people who were like clerks and people who just did, very low level white collar work, right? So it's not like they're out turning wrenches in a garage or digging ditches. These are all white collar people working in offices with relatively not physically challenging jobs. So their health is not being impacted by the nature of the work per se. And what they found was people who were in the lowest grade. So you have a grade is like a rank, like a military rank. So you have a low grade employee is somebody who has relatively low status, relatively speaking, lower income, versus people who are at the highest levels of the civil service. So these would be people who are working, under politically appointed leaders. And the study found that employees at the lowest grade had 6 times the likelihood of dying from heart disease as people at the high end. And what they found was, of course, people at the low end tended to smoke more. They tended to be more obese. They tended to have less leisure time. And they tended to have high blood pressure. But even after we controlled for all those things, the evidence was that they still had a higher likelihood of death. And so the conclusion from the study was, it's not so much it wasn't the health behaviors that were causing the higher likelihood of heart disease. It was the stress from being lower socioeconomic status. And so there's this whole, it's a lot, these are very, very famous studies. And so the discussion is that being low status, right, being a person who has to, follow the orders of other people all day long, being looked down on maybe by the people who are above you in the social hierarchy creates a sense of stress, and long-term stress tends to lead to especially uh, 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 diseases like heart disease, but also cancer, and there are a number of other diseases that arise from exposure to long-term stress. So the other video I asked you to watch dealt with culturally competent healthcare. And hopefully at this point you see the relevance to special populations. So the definition from the video: cultural competency requires a commitment from healthcare providers to be responsive to the different attitudes, verbal cues, and body language of the patients they're caring for. And one of the points they made in the video was, it doesn't require that if you're a provider that you use the same methods as the country, or in this case, or I added culture of origin of the patient, but it does require the healthcare provider to try to understand the traditions and the culture of their patients. And this is where I think the whole point of culturally competent healthcare is the provider. The onus is on the provider to understand the patient and do their best to try to meet the patient where the patient is. And so the video talks about this idea of class, culturally and linguistically appropriate services. And they've got a series of guidelines. And the goal is to make everyone feel like they're being listened to, that they're not being disrespected. So like one of the things that would be appropriate if you're dealing with the LGBTQ community is to avoid using sir or ma'am with your patient population. Now, this is a thing that if you grew up in the South or you spent time in the military, you're going to have a hard time kind of shaking off, because it's been beaten into you. For me, this is a thing. I still do it all the time. And it is meant as a form of respect, but it can also be interpreted as not being inclusive. So if you are a provider, a healthcare provider, you are making a commitment to be inclusive, to be caring about anybody who steps into your clinic, into your hospital. And so the idea here is to choose language that is as neutral as possible, that doesn't exclude anybody. And one of the things to do is, because everybody is an individual and everybody is different, is to ask patients what components of their cultural care do they want the provider to integrate, right? So it's always appropriate, in my mind, it's always appropriate to ask, and I think there's some differences of opinion out there these days about that, but I feel like it's always appropriate to ask, if you are a service provider, to ask what your patient, in this case, your resident, if it was a nursing home, would like to have, and then to accommodate to the degree possible. And I would say one of the things, I've been married. We just had my anniversary the other day, and been married almost 30 years. And my wife will sometimes talk to me, and then she'll be like, "You're not listening to me at all." And I'll be like, "Oh yeah, I heard you say blah, blah, blah." And I'll repeat back what she just said. And she'd be like, "Yeah, you were you heard me, but you weren't really listening." Right. So, and you probably have experienced this before. Someone could repeat back exactly what you said, but they didn't comprehend what you were trying to explain. And so to me, that's the difference between hearing and listening. Right. So, one of the points that's made in the LGBTQ video was, providers will give you a form and they'll say something like, "Are you married? Yes or no?" Well, yeah, I'm married, but that doesn't mean I'm in a heterosexual relationship. And so I do a lot of my research that I do here at UNH is qualitative. So what that means is I do a lot of interviewing. So I don't do surveys. I sit down with a person and ask them a lot of questions about their experiences. So for me, a management person, so their experiences as a leader, for example. But a lot of quantitative researchers will create a survey and then send someone, a survey and ask them to check, or rate on a scale of 1 to 5, something. And the risk with questionnaires is they kind of presume a specific range of answers, and they might not be asking the right questions at all, right? Or if someone checks a box saying, I'm a man, or I'm a woman, or yes, I'm married, the answer may not be what you as the person receiving the form thinks it means, right? So if you hand a form to a person, a patient, and they check man, you may assume they're a biological male, but they may be a biological female that identifies as a man. And so that's the risk as a provider in using these questionnaires. Nobody is perfect, and perfection is unattainable. But the goal of healthcare and of being an effective healthcare provider ought to be to try to be inclusive. So care providers really just need to be aware that the patient might have a different identity and therefore a different linguistic set, from the provider. What they say and how they behave may not be consistent with what the provider is used to. And so it's really important to pay attention as a provider. And it's important if you're working in a health system to create systems that embrace inclusivity. There's a relatively new concept, relatively meaning the last 25 years or so, called patient-centered care. And I got this definition of patient-centered care from the New England Journal of Medicine, which is one of the premier medical journals in the world. And the definition of patient-centered care, as you can see here, really focuses on the provider paying attention to the individual's specific needs and desired health outcomes. So it's important for the provider to ask the individual patient or resident or or client what they need and want, and then try to accommodate that. And the patient, under patient-centered care, the patient is regarded as a partner, where the provider is trying to counsel the patient rather than direct the patient. And the care delivered should be not only clinical, but also take into account the emotional, mental, spiritual, social, and financial needs of the patient. Like I mentioned earlier, my former colleague, the nutritionist, recognized that she wasn't necessarily paying attention to the financial ability of a patient to, for example, be able to afford fresh fruits and vegetables. This is a cool graphic that I liked from the same article from New England Journal. And really the focus is on putting the patient at the center, and respecting the patient and the patient's values, right? And trying to orient the care around the patient, full disclosure, right? And transparency, so that the doctor's not holding back from the patient what's really going on and what the real potential is. Care is collaborative. And so there's a great book by a physician named Atul Gawande, and he's a physician out of Harvard Medical School. He's a general surgeon, I believe. He writes for the New Yorker, amongst other things. So he's he's a pretty amazing guy. He wrote a very good book called Being Mortal, and talks at length about this idea of patient-centered care. And what he talks about in that is talking to patients. So he, as a general surgeon, he deals a lot with cancer, so like colon cancer and things like that. And so, oftentimes the patients, has to make serious choices about, so if we do this operation, for example, you might be able to, live 3 more years, but you'll have a colostomy bag. You won't be able to do this or that. And so, his goal then is to be transparent about the patient's options, and then counsel the patient about their choices and help the patient make a choice for themselves. And this is kind of goes back to the lecture that we did for long-term care, right? So the Eden alternative, a big part of the Eden alternative is to give the residents in a long-term care facility more autonomy, more ability to make choices, because you can't be a full human being if you aren't enabled to make choices about your own personal growth. And really just, it comes back to everybody deserves to be treated as an individual. And so I want to close on that thought. People aren't populations. So yes, we have special populations within our within healthcare. And we should be aware of that, right? We should be aware that women have on average different needs than men do. That maybe African American, Hispanic, or Asian American populations have different needs from, say, the average white population. But the idea that there's an average white is an overgeneralization, because if you are, you can be classified as white and have a very different backgrounds, not only socioeconomic status, as we discussed, in terms of income, but cultural backgrounds, cultural beliefs. And so a good provider treats an individual as an individual, not as a member of a group. It can be useful to generalize for some purposes, but there's a significant risk of overgeneralizing, of treating all Hispanic people the same, treating all Black people the same. And your book, like I said, does a nice job of breaking down the general Asian category into many different subcategories. And I think that demonstrates the risk of overgeneralizing. There is an old adage that says, never try to cross a river that is on average 3 feet deep. And I think that's worth kind of holding in mind when you are thinking about special populations, right? And so the idea of, if you're trying to wade across a river if you can't swim, right, and you're trying to cross a river that's on average 3 feet deep, well, it might be 2 feet deep for the majority of the river, and then maybe there's a 10-foot drop off right in the middle. But on average, it's 3 feet deep. So you can wade out until you can't anymore, and then you drowned. So people aren't populations. I think that's kind of, that's probably one of the most important things to take away from this chapter. All right, onward to chapter 11 or 12.